Everyone, thank you for joining. This is Susan McDonough from DataGen. DataGen helps support your state hospital associations and multi-state health systems with some of their Medicare fee-for-service policy and analytic work. We're happy to be here today at the request to present to you a highlight of the Medicare fee-for-service 2020 inpatient proposed rule and the analyses that DataGen does in concert with your association and multi-state health system. Due to the large volume of folks on the line, the calls are muted. At the end of the call, we'll have time for questions and answers. You can use the chat feature at the top of your screen to pose those questions. Today's webinar is being recorded, and the PDF of the slides and the recording will be made available to you after today's call through your association or multi-state health system. Without any further hesitation, I'll turn the call over to Bill Shine, who's going to do the first part of the presentation, followed then later by Lauren Davis, who will talk to the quality component of the proposed rule.
Good morning, everyone, good morning to some of you. Good afternoon to everyone else. So with this inpatient proposed rule overview, we'll be going over some of the rate updates that occurred, the changes to the DISH, traditional and or uncompensated care pool, the changes to the wage index, which I'm sure many of you are quite interested in, changes to GME, changes to inpatient excluded hospitals, as well as the quality programs, which Lauren Davis is going to be going over after the rest of this. First up is the rate update. For fiscal year 2020, CMS is proposing a market basket update of 3.2%, which is equivalent to $3.4 billion nationally. This is reduced by the Affordable Care Act productivity adjustments of 0.5 percentage points, which is equivalent to about $500 million. Note that 2019 was the final year of the predetermined adjustment due to the Affordable Care Act, and for that it was 0.75 percentage points. Note that this is probably one of the higher update factors that you have received in many years due to this predetermined adjustment going away. Net of the productivity reduction, the market basket update for 2020 is proposed at 2.7%. Note that this proposed market basket update is not necessarily what everyone will receive. For those hospitals that fail to comply with the electronic health record and institutional quality reporting programs, there are reductions to this update. If a hospital fails to comply with the IQR program, they will lose 25% of their base market basket, the base market basket being the 3.2%. In other words, that equates out to 0.8 percentage points. For those that do not comply with the AHR meaningful use program, that's 3/4 of that value, or 2.4 percentage points. Now, with the proposed rule, CMS did release a set of flags for those hospitals that may or may not receive a penalty come time the final rule. This list is usually in flux up until the point of the final rule release. However, for those hospitals that are solely affected by the meaningful use penalty, CMS is projecting out 228 hospitals, which is a 50% increase over fiscal year 19. And there are 41 hospitals projected to be penalized solely by the IQR penalty. Meanwhile, there are 37 hospitals, nearly equivalent to those affected by the IQR program alone, that would be affected by both and would lose their full 3.2% market basket. 2020 is also the third year of the retrospective adjustment for the ATRA 3.9% coding adjustments. For those that may not recall, the ATRA reduction was meant to offset payments that hospitals should not have received due to coding changes. It was at 0.8% per year from 2014 to 2016. It was expected to continue to be 0.8% for 2017. However, CMS threw a curveball and increased it to 1.5% or 1.5% reduction for that year. Note that under MACRA, Congress, instead of what would have been a 3.9% return in 2018, extended out the return period for this cut over a course of 6 years at 0.5% per year. Note that this was likely tied to the projected 3.2% reduction that hospitals were estimated to receive prior to CMS increasing the reduction in 2017. As a result, by the time 2023 rolls around, hospitals will be about 1% in the hole versus the original 0.2% in the hole due to ATRA. Net of these adjustments, the federal operating rate is proposed to increase by 3.14% or to $5,800 per discharge. That is prior to any wage index or DRG adjustments, while the capital rate is proposed to increase by a little under 1%. For the operating rate, 3.14% is made up of the 2.7% market basket increase, net of the productivity adjustments, the increase of 0.5% due to MACRA, or the retrospective coding adjustments, as well as a small reduction due to budget neutrality, which is inclusive of the budget neutrality adjustments due to the 5% stop loss that CMS has been implementing or proposing to implement for fiscal year 2020. Onward to Medicare DISH. Every year, CMS calculates a baseline DISH pool. This is what they project out would have been paid out under the traditional DISH formula, under which hospitals receive a multiplier based on their annual DISH percent, whether they're an RRC, rural, how many beds they have, etc. For fiscal year 2020, CMS is projecting out a total DISH pool of just under $17 billion. Now, since 2014, this has been split up so that the traditional DISH method is reduced to 25% of what it was, and 75% of this pool goes towards the uncompensated care pool, which is then reduced depending on the national insured rates, and then distributed to hospitals based on, in the past, it's been Medicaid and Medicare distributions, and CMS has been moving towards and is looking to finalize their movement toward using the uncompensated care ratios that each hospital has based on Worksheet S10. For 2020, the available DISH pool, the amount that's actually going to be distributed, is proposed to be increasing by about $200 million. And CMS is also proposing that they will only utilize a single year of Worksheet S10 data and a single year of data, period, to distribute these funds. This would be the fiscal year 2015 audited S10, line 30. This is certainly a departure from prior years, as since 2017, CMS has utilized a 3-year averaging methodology in order to balance out any sort of year-to-year fluctuations. Note that in 2019, those 3 years of data were inclusive of fiscal year 2014 and 2015 S10, with fiscal year 2013 Medicaid days and 16 SSI ratios making up the third component. CMS is also proposing, well, less proposing, they're seeking comments on whether they should instead use fiscal year 2017 data. As a large piece of why they were proposing to use this audited 15 data is, well, is audited, so you think you can trust it a little more. However, this continues on with their 2017 data comment request, as hospitals would have more experience with the S10, and thus 17 would likely be possibly equivalent to an audited 15. As I mentioned earlier, this single year of data would be a departure from the 3-year averaging that they currently use. Some other changes that CMS is proposing for Factor 3, or the distribution: all-inclusive rate hospitals. Currently, they are excluded from the trimming methodology that CMS applies to the S10 data. In fact, they don't even have S10 data used at current. Currently, because of the variance that their cost of charge ratios have relative to all other hospitals in the country, CMS actually uses 1 year of Medicaid and Medicare SSI days data sets as their full weight in order to determine their Factor 3. However, for fiscal year 2020, CMS is proposing to, well, keep them out of the trimming methodology, but is proposing to use their S10 data. They believe that any sort of trimming to the cost of charge ratios that will be applied to the all-inclusive rate hospitals will mitigate any sort of aberrant CCRs that they may have. Also, for new hospitals, for those that are with Medicare certification numbers created on or after October 1st of 15, CMS is proposing that these hospitals would not receive interim uncompensated care payments, but would instead be paid their full uncompensated care amounts at cost support settlement. Their Factor 3 would be determined based on their fiscal year 2020 S10 numerator, as S10 value as the numerator, with the national fiscal year 15 value, that which is applied to all other hospitals for 2020 as the denominator. When looking at the difference between the uncompensated care factors, the 3-year with 2 years of S10, 1 year of the traditional, and 19 versus the 1 year of 2015 in 2020, you do see some major fluctuation in the distributions for each individual state. You have those that are expansion states that, well, Medicaid expansions that do tend to take a major hit as they are losing that Medicaid and Medicare SSI days component to their Factor 3, which traditional DISH was based on, and thus they're losing out on the S10 piece because Medicaid shortfalls are not included in line 30 of worksheet S10. However, keep an eye on the values for Montana and Alaska. You see Montana being at roughly an 8% increase for using the 15 data, and Alaska about a 24% increase using the 15 data. If CMS were to use the 2017 data instead, there's a major decrease there. Montana would see a 34% decrease instead of the increase that they would have seen otherwise, and Alaska a 24.5% decrease instead of their fairly large increase. Other states do have swings as well. Some swing more than others, but these two states were very good examples of what happens when there's only a single year of data being used for this distribution, that a swing will likely occur year to year because the data doesn't remain consistent, especially with uncompensated care. However, if the data were to continue with a 3-year averaging, things balance out a little bit. You have some states that still receive large decreases, but that would be the case because the proxy data is going away. As a result, generally they are the expansion states. However, it's muted. Large increases, large decreases will not happen quite as much. I understand that some may prefer having a 1-year factor, largely because of how their data happen to be. But simply because of how things work, a 3-year average would likely result in more long-term stability as far as these funds go. As for wage index, CMS is proposing to modify how the overhead rate calculation is put together. As currently, that calculation includes overhead contract hours in, well, the denominator of the revised total hours, but not in the numerator. They're proposing to just remove it entirely from the being subtracted. This makes sense simply because why subtract out something that has no impact on it? Also, for the calculation, they're proposing to round the wage data within the calculation to 2 decimals and hours to the nearest whole number. Any sort of non-wage or hour data ratios will be rounded to 5 decimals, and they are proposing to continue rounding the calculated wage index unadjusted and adjusted for occupational mix to 4 decimal places. This is so that everyone, whether you're within CMS or an outside consultant, if they were to calculate the wage index, everyone should come out to around the same number and have it not be due to rounding. CMS also has a proposal for those CBSAs that do not have hospital wage data. These CBSAs would have their wage index set to the average urban wage index of the state where the hospitals within them are located. Currently, the only 2 CBSAs that will be affected by this are Carson City, Nevada, and Hinesville, Georgia. Also, fiscal year 2021 reclassification requests are due to the MGCRB by September 3rd. And related to this, CMS is proposing that the supporting documentation that hospitals send in no longer needs to be copied to CMS. This is just an overhead that CMS feels hospitals don't need, and sending it to the MGCRB is sufficient. As far as the rural reclassifications, CMS is proposing that hospitals will now have up into 120 days prior to the end of a fiscal year to cancel their rural reclassification for the upcoming fiscal year. They would also allow rural reclassification applications to be sent to the CMS regional offices by fax or email or other electronic means. Currently, the regulations require it to be in paper form. For rural referral centers, currently, they must be paid as rural for at least one full 12-month cost reporting period prior to canceling their rural reclassification and gaining a MGCRB reclassification. However, as the MGCRB has made it so that those reclassifications as well as the rural reclassifications may be made simultaneously. CMS is proposing to no longer require that 12-month period. For those counties with Lugar status, CMS is proposing that, or actually clarifying rather, that if a county is no longer eligible for an out-migration adjustment by the time an inpatient final rule is released, any hospital that chose to waive their Lugar status post the release of the proposed rule will automatically be reassigned their Lugar reclassification, even if once those Lugar reclassifications are reassigned, an out-migration adjustment would make it more favorable. The issue being that if too many hospitals were to have the Lugar reclass, or were to waive their Lugar reclass rather, the out-migration may go away, and thus waiving the Lugar reclass would be disadvantageous. CMS is also proposing to increase outlying counties in their commuting analysis for the determination of where counties are set to for their Lugar status as far as CBSAs go. The 10 counties affected by this proposed changes to the Lugar calculation are on this slide. You would have that in your packet, I believe, Susan included?
Yes.
Yes. Now, CMS in 2019 sought public comments on wage index disparities and how to remedy them. Some of the comments that they received last year pointed to a common concern that the current system perpetuates the existing wage disparities between high and low wage index states in particular. There's also concern over the manipulation of the rural floor calculation in order to increase the wage index of certain states at the expense of others. Targeting this in particular for fiscal year 2020, CMS is proposing that urban hospitals that redesignate as rural would no longer count towards that state's rural floor calculation. Their wage data would not go into the rural wage area. They would remain solely in their own urban CBSA. CMS is also proposing an opportunity to increase employee compensation. This proposal would increase the wage index of hospitals in the bottom quartile of wage values nationally. Their new wage index would be set to the halfway point between their base wage index value and the 25th percentile value, or the average of the two. This proposal will be effective for fiscal year 2020 and in effect for at least 4 years in order to allow for any sort of increased wages to make it into the cost report in order to maintain this higher wage index value. Note that this is a use it or lose it proposal in really no uncertain terms as far as how CMS proposed it. Assuming that hospitals do not funnel this into wages and instead bundle it away into infrastructure or something like that, their wage index or the wage index of their CBSA will likely plummet again after this proposal ends in 4 or so years. However, note that there is kind of an offset to this. Even if certain hospitals were to increase their wages, if not all hospitals in their CBSA do so, and some of them don't stay with the pack and, again, funnel it into infrastructure or something else, those hospitals that did increase their wages would likely see a loss. once this increased wage index ends, simply because unless you are the hospital that drives the wage index in your area, the wage data would not continue to support having the increased wage index, and thus your revenue from inpatient Medicare would decrease. Also note that, as many of our clients have mentioned, not all payers may choose to mirror what CMS is doing. As a result, again, you would have to decide how you are going to increase the wages, and it may not be to the level that Medicare increased the wage index. And thus, your wage index may increase somewhat, but not as much as it started at. This proposal does have a budget neutrality offset. There is no such thing as new money as far as Medicare is concerned, or rarely is. CMS is proposing that this offset would apply to the top quartile of hospitals as far as their wage values go. Those wage index values would be reduced by 4.3% of the difference between their wage index and the 75th percentile wage index value. So it's not a complete mirror. For all the changes that CMS is making to the wage index this year, or proposing to make, CMS is also proposing to implement a transition period by implementing a sort of 5% stop-loss adjustment on a hospital's wage index. This proposal would be that a hospital's fiscal year 2020 wage index, note that this is only 1 year, could be no less than 95% of their final fiscal year 19 wage index. As a result of this transition, CMS is applying a budget neutrality offset to the rates. This applies to all hospitals, as it's the base federal operating rates, as well as the federal capital rates. To the federal operating rate, CMS is proposing to reduce that by 0.17%, and to the federal capital rate, which is not on this slide, by 0.27% to account for this stop loss for 2020. When you look at the changes to revenues under inpatient Medicare, under state by state, due to this wage index change, really it's the Deep South and Rust Belt that tend to make out a little bit more than others. Meanwhile, those that are historically high wage index states do see a loss. However, there are states that do have lower wage indices that you would think would be helped by this, but at least for 2020 aren't, which is a result of the 5% stop loss budget neutrality. So as I mentioned, you have hospitals that their wage index is not going to be reduced further than 5% less than their 2019 value, but there is that component that reduces the federal operating rate. For many hospitals that are close to the bottom quartile wage index value, this outweighs really any increases they get from the 75-25 proposal. Now, looking at the data, this 5% stop loss is weird. Some of it, is this actually working as intended? It's not, depends on what the intention is. In most cases, when looking at the impacts, the adjustment will be due really entirely due to the wage data changes between fiscal year 19 and 20. The majority of providers, the reason why they got this 5% stop loss adjustment is because the wage data of their CBSA dropped significantly between the 2 years. That could be that largely in many cases because of the rural reclass proposal, as many of those urban hospitals really did prop up the rural floor for many or a few states, rather. However, there are also some times where a hospital happened to reclass to rural, and this would have been a decrease. Note that this could have been related to the rural referral center change, where the hospital believed that they need to be rural for at least 12 months for reclassing. However, that decrease is also affected by the 5% stop loss. So it is not as much of a penalty as one may think. Now, why I bring this up is because many believe that this 5% stop loss, they don't look at that rural reclass proposal. They believe this is tied to the 75-25 proposal. However, the maximum reduction in wage index due to that 75-25 is 2%, which is certainly less than 5%. And thus, no one is going to be receiving the stop loss solely due to that 2%. A few do, where it shores up the reduction, but not many. CMS did release a file that included some alternatives that they had considered before proposing the 75-25 methodology. Their alternative number one would be that instead of reducing the top quartile wage values, they would instead apply a budget neutrality factor to the rate. As you'd expect, this spreads it out fairly evenly among most of the states. No one gets hit extraordinarily hard with it, but everyone gets hit with it. And it does come to the benefits of, as the primary beneficiaries of the proposal, the southern section of the U.S. Alternative number two would be that the reduction to the 75th percentile values would mirror the bottom quartile, and that it will be reduced to the average of their wage index in the 75th percentile. And then the federal rate would be budget neutralized. This has some very wild swings all across the country. I'm not certain of many that support this per se from who we've talked to, but I can certainly say that there will be many that would certainly like this method and those that would be very much against it. Finally, CMS did have a third alternative, and that would be creating a national rural wage index, which they had estimated at about 0.86. That would replace the current state rural floors. Generally speaking, those states with higher rural floors would be impacted more, and those with lower rural floors would benefit. Generally speaking, also, rural hospitals are those that benefit most from any of these proposals, as they tend to be impacted by lower wage data. Some other proposals that CMS had with this rule include GME, and that resident FTE slots at non-provider sites. CMS is proposing that beginning with October 1st, hospitals may include residents training at a critical access hospital, provided that all the requirements are met for that critical access hospital to be treated as a non-provider site. Those costs would continue to be paid 101% of costs for the training of these residents, but would not be able to claim them for the purposes of GME if they are treated as a non-provider. Some of the additional proposals that CMS included is a proposal to exclude ambulance services that are not authorized to transport to a critical access hospital from the 35-mile criterion that calls are subject to in order to be paid 101% of costs rather than the ambulance fee schedule. Note that for any ambulance service that is outside of 35 miles and critical access hospitals servicing an area outside of 35 miles, those would still be subject to the ambulance fee schedule. CMS is also proposing that for new technology add-on payments to increase the amount from 50% of the cost of the new service or tech, or the amount by which the cost of the case exceeds the standard GRG payment, to 65%. This also has implications for changes or potential changes to the CAR T-cell therapy payments, which are currently paid under new technology. However, CMS is seeking comments on appropriate methods to develop DRG weighting for these, as well as whether or not they should have wage index, IME, or DISH applied to them, and what sort of specific cost to charge ratios should be applied. CMS did not propose new DRG weights for CAR T in 2020 due to the current fairly low volume of cases related to them. However, they are very well reimbursed for those cases. Also, CMS is seeking comment on the rate of ceiling increases, or the ceiling rate of increase for TEFRA, and looking for new methodologies to determine an appropriate amounts of these increase, and also criteria that would warrant a new base period that would drive these increases. So as far as the reimbursement section of the inpatient rule, that is about it. However, we are going to go through walk through the analysis that your state associations have sent to you. The analysis, as many of you may have seen, as some of you may not have seen, as many of you have not have seen, depending on how many are new, there is a hospital report for this inpatient analysis. It provides the general changes that have happened year over year, be those changes in provider type, changes in the market baskets, the wage index, and how those apply to you. For 2020, there is a breakout for the proposals to reduce wage disparities, as well as changes to the uncompensated care factor 3. These indented pieces, designated the arrows, do not attempt to sum down the entire column. These pieces are breakouts of the value above them. So that $4.2 million and $941,000 for reducing top quartile and the budget neutrality add up to the reducing wage disparities line. And the additional compensated care factor change is a component of the overall UCC payment change. Below this piece, there's a breakout for additional compensated care. It provides you with your overall pool that you're working against with your factor 3, as well as the estimated amount that you will receive for fiscal year 2020. There's also a section on quality. 2019 values are the final factors that have been released by CMS. For 2020, readmissions is based on the 2019 readmissions adjustment factors, as those are the proxy values that CMS has released. They only release the readmission data periodically, actually once a year, so we are unable to recalculate that through the year. So we must use what CMS provides. While the BVP and HAC impacts are based on the fourth quarter 2018 update to Hospital Compare. The next page of your analysis includes how we arrived at these endpoints. including the component pieces for the federal operating rate, the wage index, the labor share that you received of that wage index, the adjustment factor that you would have received in 2019 and proposed to receive in 2020. This will bring you to your calculated operating rates as well as capital and overall. Also for this proposed rule, we included a section on how CMS's wage index alternatives would have affected you relative to the proposal of reducing the wage disparities as well as what it would have been without the proposal. Note that CMS did not actually propose these alternatives, but that doesn't mean that they may not be swayed by comments if many of you feel strongly one way or the other. This page also includes any sort of the DISH alternatives, impacts due to using 2015 data relative to the fiscal year 19 factor threes, also the alternative of using 2017 data alone, in addition to something we chose to include of including the continued transition of 3 years of factor three. CMS did not propose this. However, again, they may be swayed by comments if any of you feel strongly one way or the other. That's it for the direct reimbursement pieces. Now I'm going to pass over to Lauren Davis to go over the quality program changes.
Thank you, Bill. There wasn't too many proposals in the inpatient rule for the quality programs this year, but I'll start with talking about the value-based purchasing program. If you recall, in the prior year, the 2019 rule, CMS was trying to do some deduplication of the 3 Medicare quality programs as well as the IQR program and removing measures that are in more than one program. They ended up removing the hospital-acquired infection measures from the IQR program and keeping them in the hospital-acquired condition program as well as the VBP program. With this, they assigned the hospital-acquired condition program as the source for all the corrections and validations of measures as well as the reporting for hospitals. The process remained the same for hospitals other than it was going to be through HACs versus the IQR program. CMS is proposing now for VBP beginning the January 1st, 2020. CMS is going to also validate and do the review and correction process for the action measures in VBP through the HAC program as well. This would apply to the federal fiscal year 2022 program performance period. Again, the process for hospitals to submit and review data and correct it will remain the same. It will just be through that HAC program rather than through VBP. Now, for the readmission reduction program, there are a few more changes, but still not too many. CMS made some proposals for program specifications for the future. The 2022 program performance period, they're proposing from July 1st, 2017 through June 30th, 2020. This follows the same rolling performance period that has been happening since the program began, actually. CMS is also proposing a measure removal policy for the readmissions program that includes 8 removal factors. This is the same measure removal policy that they have for other programs currently, like VBP and IQR. And this is just our list of considerations to take into account when deciding if a measure should be removed from the program. This is done on a case-by-case basis. And even if a measure meets the criteria, one or more of them to be removed, this does not mean the measure will definitely be removed. It may be retained if the benefits of the measure outweigh those drawbacks based on the criteria. CMS is also proposing to adopt a process to address any changes needing to be made to the program that are not major changes outside of the rulemaking process. Currently, for the readmissions program, if CMS has even the smallest change they need to make, they have to wait until its proposed rule time period to propose the change and then finalize it at the end of the summer. CMS wants to be able to do this more frequently as needed, and therefore they're proposing this change. This could be anything from a median excess readmission ratio for hospitals and a quintile, peer group assignments, anything that wouldn't really be substantive to have in a rule. CMS is also proposing to update the definition of dual eligibility beginning federal fiscal year 2021. If you recall, CMS began the sociodemographic status adjustment in the readmissions program last year in federal fiscal year 2019, and they retained the same adjustment for federal fiscal year 2020, where hospitals are grouped into national quintiles based on their ratio of full benefit dual eligible patients to their total Medicare patients, and are compared to hospitals within their quintile on the measures. CMS is updating that definition of what they consider dual eligible, and I'll talk about that on the next slide. But for example, this is something CMS uses in the rule as a change that they can make outside of rule-making process because it doesn't affect hospitals that much, and I'll talk about that in a couple minutes. And then the final proposal for the readmissions reduction program is just that CMS is going to be releasing some confidential reports of data, hospital-specific reports by dual eligible status as early as spring 2020. And again, I'll talk about the details of these in just a minute. So, as I mentioned, CMS is proposing to update that definition of dual eligible status specifically for those patients who die in the month of discharge. Currently, CMS is under-reporting for these patients because those who die in the month of discharge either were not their dual eligible status was not reported during that month, or it changed from the prior month. So CMS is proposing a 1-month look-back period in the file that they use to identify full benefit dual eligible patients to see if those patients were, in fact, full dual eligible or not. And this will not make much of a difference on many hospitals' ratios, but in order to not miscount, they will start that in the 2021 program if it's finalized. And then as far as those confidential reports that CMS is going to be releasing as early as spring 2020 for hospitals, they're going to stratify data for hospitals by patient dual eligible status for each of the individual measures. Just want to point out here that these reports are not going to be used in the actual readmission reduction program adjustments. They're just for informational purposes and comparison for hospitals, but will not affect the hospital's score. They're using 2 different methodologies for reporting. The first is the within-hospital disparity method, and this will look at differences for dual-eligible patients within a hospital and non-dual-eligible patients within a hospital on the different measures. And then the other methodology is a dual-eligible outcome method, and this compares performance for dual-eligible patients on these measures across hospitals. And these are no additional burden to hospitals. This data is already available in the claims data, but just for informational purposes, so a hospital can see how they're performing within their hospital as well as compared to other hospitals. CMS is going to make this data available. And finally, for the hospital-acquired condition program, again, there's not too many changes in this program that CMS is proposing. They talked about some of the specifications for the 2020 performance periods, some measure time frames that they're proposing, and they're also proposing to adopt that same 8 removal factor measure policy that they are proposing for the readmissions, and that's already in VBP and in IQR. And that's that. So I'll pass it back to Susan to talk about any other questions that you may have.
Hi. When you logged into today's webinar, you may have seen the PDF of the slides for today's presentation. Regardless, the PDF and the recording will be provided to your state association and multi-state health system corporate office for distribution to those that registered for today's webinar. So yes, the slides and the recording will be made available. There is still 10 minutes or so. If anyone has questions, we recognize we rattled through these slides quickly to ensure we covered it all and also to allow ample time for Q&A. We recognize that you've got the brief and the analysis specific to your facility in your possession, but seeing these national maps might trigger some additional questions on either the wage index or the DISH, which seem to be the two juiciest parts of this proposed rule and have been subject to a lot of discussion since the analysis release. So we welcome any additional questions using the chat feature at the top of your screen. Again, the lines are muted due to the large volume of participants on today's call. Again, the chat feature, not the Q&A feature at the top of your screen, is available for any questions you may have. Comments on the proposed rule are due back to CMS. I think it's June 24th, but the specific date is written in the inpatient proposed rule brief that you've received. I'm not seeing any other questions. I know everyone's time is extremely valuable. We appreciate the time you spent with us learning about the proposed rule and the analyses that supports it. And enjoy the rest of your day. Thank you very much. Bye-bye now.